University, and currently he's scientist and clinical associate professor with the section on public psychiatry and mental health services at the University of Pennsylvania in their Department of Psychiatry. And as I said last week, he was previously Director of Planning, Evaluation, and Data Management with the Philadelphia Office of Mental Health and Mental Retardation. And Dr. McGurrin today will continue with his talk on suicide.
Thanks. Welcome to part two of the presentation that I'm making on suicide. About 2 weeks ago, you were dealing with a major blizzard and snowstorm, and today on the way up I kept hearing on the weather news that the ground is so saturated that all of the local streams and rivers are overflowing. So I guess in another 2 weeks we'll be through with this winter's major weather catastrophes and can be more relaxed about the weather. In any case, I'm encouraged to see that in spite of the bad weather, there's a good turnout, and I'm pleased to be back to present part two of this presentation on suicide. I mentioned last week that the session today would focus pretty much exclusively on shop talk, practical issues that should be of some value and relevance to people who are involved in and responsible for the treatment and management of persons who have serious and persistent mental illness and who are at much higher risk of attempting and committing suicide than persons who are seen in community systems or in private practices or in the general population, because although it's not totally clear why this is the case, persons in institutions have a much higher, much more elevated risk of attempting and committing suicide, and persons who suffer from different types of affective disorders as classified in the DSM-3R also have an exceptionally high level of risk. And when you combine these two factors, you have a kind of at least additive, if not multiplicative effect of increasing the risk of suicide and attempted suicide. So it's an issue that has particular relevance for persons who are involved in the treatment and management of psychologically distressed persons in a state hospital. I want to begin by providing some continuity with last week's material by looking briefly at one of the third types of generic methods of studying suicide. You recall last week I mentioned that there were basically three general approaches or methods for studying suicide. One method looked at diagnostic and demographic characteristics of clients or patients to see if there were certain indicators that occurred frequently enough to serve as at least useful benchmarks, if not predictors, of risk of suicide. And then there are the larger scale epidemiological predictive studies that utilize large numbers of cases, out of which only a very small percentage commit suicide, and they look at and compare these populations in terms of mathematical models. We really didn't spend any time looking at examples because I've decided in my experience in presenting this material that these epidemiological models are the least interesting and relevant to people who have to deal with individual cases. but I think it's important that you know that method exists, and had we looked at examples of those studies, one would have shown a comparison of suicide rates among persons from 14 to 21 over about a 6-year period for the entire United States, compared with a group of persons 65 and older for the same time period across the United States, and it would have indicated that around 1970, 72, that the rate of suicide and the risk of suicide for adolescents began to climb very rapidly, and up until that time was about at the same level, almost parallel and overlapping with the rate for geriatric persons. But around the early mid-70s, the adolescent population elevated very rapidly and stayed at an elevated level, while the geriatric population actually began to taper off a little bit. And the explanation that the authors in this study propose, and it's a very speculative one, is that because of the increasing aging of the population, older people feel less alienated, have more opportunity for companionship, and are really the focus of more attention on the part of policymakers and the general community than they have been in the past. That while aging still carries the problems that it will probably always carry with it, being old is not being so strange or unusual anymore because the population is aging. The proportion of people over 65 is increasing. Whereas for adolescents during that same time period, the increased abuse of substances and increased access to firearms took place, so that there were two different sets of factors operating, one to actually suppress the risk of suicide, the other to elevate it. It's an interesting piece of information to have, but it really doesn't tell you very much about what you ought to do with Mrs. Jones, that's your patient, and ingested some poisonous substances last week. Making the jump from that kind of data to practice is not easy. A third example is kind of a bridge between case studies and predictive studies, and it goes under the general title of stressful life events. And I've selected just one study that we'll look at very quickly to provide continuity into the case study approach, which has great relevance and application in a treatment setting. The study that we'll look at very briefly was conducted by Pakel, Bridget, Pressoff, and Myers in New Haven, Connecticut. These folks are all part of the School of Medicine and Department of Psychiatry at Yale University. And they were responding to the fact that previous literature had reported in a not too systematic fashion that persons who had attempted suicide have been reported to experience more often than the general population the recent death of a parent or a spouse. And another investigator had reported that attempted and successful suicide cases had more often than typically experienced some type of separation from a spouse or family members, and that these types of almost anecdotal information had never been systematically investigated to determine if recent stressful life events are in fact relevant predictors and somehow discriminate between people who are likely to attempt suicide and commit suicide from other psychiatric patients and from the population at large. So they looked at 3 groups, and this, at least in terms of study design, this is a reasonably sophisticated study. They had one group of 53 patients who had attempted suicide and were aged 18 years and over, who had been admitted to the General Hospital Emergency Service in New Haven, Connecticut, immediately following the attempted suicide. They had another group of 53 subjects who were selected from a larger group of 185 diagnosed depressives, and these 53 selected subjects were matched with the suicide attempt group on age, sex, marital status, social class, and race. Since they could not randomly assign people to groups, they did the next best thing. They matched them for these characteristics. And then finally, they had a group of 53 persons selected from what they call the general population. Actually, it was a group of persons who had been included in a fairly comprehensive community study done in New Haven, Connecticut on the incidence and prevalence of mental illness in that community. New Haven, as you may know, has been studied more frequently than any other community in the world, I suppose, for incidence and prevalence of mental illness. So it's well known for its psychiatric profile. So they had these three groups: people who had attempted suicide and may have, and in many cases did, also had some type of psychiatric disorder; persons who were depressive but had not committed attempted suicide; and then persons from the general population, about which we know very little, except that they were well enough to function in the community without any support or assistance. And they looked at a variety of different events that they felt could be conceived of as, thought of as stressful life events, to see if there was any difference between the three groups: the suicide attempters, depressives, and general population. And you'll see from looking at this table and from the investigators' discussion that overall suicide attempters experienced substantially more events than the general population subjects, and a definite but less marked excess compared with depressives before onset of depression. In terms of the category of events that were most significant, serious illness, let me go right up to the top of the table. Serious arguments with spouse was much more frequent among people who attempted suicide than among the other two groups, and this gives the level of statistical significance, which is rather high. Serious illness, a new person in the home, which could be a child or it could be an in-law coming to live, but a new person entering into the home was more frequent among suicide attempters. Serious illness of a close family member, spouse, child, parent, sibling, or fiancé, and serious personal physical illness were all much more frequent among suicide attempters than among either of the other two groups. And that was not just by chance alone. It would appear to be a statistically significant finding. Legal actions, court appearances for some type of offense or a lawsuit was also much more frequent among the suicide attempters than among the general population, and combined slightly more significant than even among the depressive population. And finally, moving from one location to another, moving their house or apartment, was much more frequent among suicide attempters than either of the other two groups. After that, the frequency begins to fall off. So we see there are two or three general categories of recent life events that seem to be significantly associated with a higher risk of attempting suicide than is true either among psychiatric patients with depressive disorders or among the general population. And I'll just show you how this looks very quickly in terms of a set of lines. No, I'm sorry. The other aspect of the study that distinguished the suicide attempters from the other two groups was the recency within which the stressful life event occurred. That among those categories, personal health or health problems with someone in the family, tension and conflict with a spouse, legal difficulties moving from one location to another, the most frequent occurrence and the mean number of events reported for the suicide attempters occurred most often within just 1 month prior to the occurrence of the suicide attempt. Whereas with the other two groups, it occurred somewhat regularly throughout the 6-month period. There's a slight elevation for depressives 1 month prior to being diagnosed as depressed, but it isn't nearly as high as the triangular marked line for the suicide attempters, so that it's recent stressful events that are most significant as the predictors and discriminators for suicide attempts among persons who were admitted to the hospital in New Haven for this reason. Now, this is one study. It doesn't involve a large number of cases, and I don't think that anyone would want to make any strong generalizations from it, but it does support the prevailing notion that has existed for some time without any evidence that stressful life events are significant factors and issues that we should be aware of and sensitive to in dealing with persons who are under our care. The next most common and for us the most interesting method are case studies, where you look at an individual case and attempt to get as much detail as you can about the conditions that were related immediately in the past and around the time of the suicide or suicide attempt, and what was done as a means of intervention. And we'll look at information related to case study data and its application in a hospital setting in just a few minutes. But before that, I'd like to first address an issue that is frequently thought to be an important part of talking about suicide management, and that is the issue of medication. As I said to you last week, there really is no medication for suicide. Suicide is not a disease, and it is not a condition that can be specified in a way that you can prescribe medication to prevent it or to treat it. What you do is treat the disorder that the person has, and if that disorder happens to be associated with a higher risk of suicide, then in an indirect way you are intervening with medication. There is no medication for suicide. Because suicide is so frequent among persons who are suffering from affective disorders, any of the medications, tricyclics or otherwise, that are used as antidepressants are probably the most frequently utilized medications in treating persons who end up attempting suicide. There are a few practical points to consider, however. One of them is that in monitoring persons who are depressed and have recently, and I mean seriously depressed, and have recently been placed on medication to receive relief from those symptoms, there's a period that runs about 2 to 2.5 weeks after they go on the medication, especially if they are using it regularly as prescribed, when they will begin to experience sufficient relief from the depression to sense that they can actually do something to prevent or change the recurrence of that depression. And for a certain number of persons, a disturbingly high number of persons, the conclusion is they will end their life, and that way they will never become depressed again. So that there's a period of time, 2 to 3 weeks after a person is on medication, especially the antidepressant medications, when you want to watch very closely to make sure that you don't get too distracted with the progress they're making to recognize or fail to recognize that that may include a sense on their part that they may never feel this well again, and that when they were truly overwhelmingly depressed, they couldn't even organize their thinking and summon enough energy to commit suicide. They were helplessly depressed, so much so they couldn't even kill themselves. When they start to get a little better, they can entertain that notion and will act on it. I think probably many of the cases, you may be familiar that Prozac received a lot of bad press for a while because people were maintaining that it caused suicide. There aren't any drugs that you can use to treat suicide. There aren't any drugs that cause suicide. It's not that simple an event. But what was not discussed in the bad press on Prozac was that it had been a relatively effective drug for many people, and that there is about a 28-day period that you need to use it consistently to really begin to stabilize and benefit from that particular medication. And people were using it and benefiting from it, but the focus was more on the 28-day period than on the first couple of weeks. And people, I believe, were committing suicide because they were getting better, not because Prozac was making them commit suicide. And this is something that is true for all of those medications. The other point is that of all the poisonous substances used in the last 5 years among suicide attempters and successful suicide cases, the one that occurs most frequently among psychiatric patients are the antidepressant medications. And they're often used in combination with alcohol. So that while, again, the medication is not the cause of the suicide, it becomes an instrument of suicide, and it becomes very important to monitor the patient's actual ingestion of the medication on a regular basis. One of the reasons why this happens to be true, it appears from the literature, is not something that folks like you have that much responsibility for or control over. About 60%, and I was amazed at this statistic, in one study, about 60% of the prescriptions written for antidepressants are not written in hospital settings, but they're written in the community by general practitioners who do not monitor in the same way that a psychiatrist or a mental health professional would, because they operate their practice differently. I'm not criticizing the general practitioner, just pointing out that they're in an area where specialty and special knowledge is particularly important with regard to suicide. And so one of the reasons why, again, these antidepressant medications show up as related to suicide is because of this practice of writing prescriptions. And they're not written, the records and the studies that were done to interview physicians who had written them don't always write them for depression. They write them for other kinds of conditions. So that the whole issue of how to use antidepressants and how to monitor their use is something that requires a good deal of attention and understanding on everyone's part. Now, the final bridge with last week's session is to point out again, and I've been indirectly remarking on it already, that when we talk about causes of suicide, we have to recognize we're talking about a certain kind of causal model. We're not talking about cause and effect in exactly the same way that we do in the logic of the physical sciences. I'm talking about cause and effect in terms of concepts such as intention and meaning. We're taking the position that suicide is not essentially and totally an involuntary action on the part of the person who commits suicide or attempts it, in the way that my glasses will fall to the floor, complying with the principles of gravity. If I drop the glasses fall, they don't have an intention to fall. That was Aristotle's confusion. And maybe 500 years from now, we will look at human behavior and see that we're not much different from a pair of glasses. But at this point, clearly that's not the way it's regarded. And when we talk about cause and effect, what we're really talking about is what's the meaning of suicide for the person who attempts it, who commits it, for the people who treat them, for the family members, and for the community. This is what we mean by cause and effect. Meaning and intention. Any effective effort to intervene and manage the problem and phenomenon of suicide in a treatment setting like Harrisburg State Hospital has to be understood in terms of a flow of suicide information. And that flow begins at admission. And this is how I would like to proceed now to talk about the way in which you can make some efforts to identify persons at risk, intervene, keep records on this, and we'll look at the case studies in conjunction with this. Admissions is the first point in this flow. I understand from talking to Jim that there's a group here at the hospital, I think perhaps primarily consisting of psychologists right now, who are looking at the topic of suicide and procedures and techniques that can be used here in this hospital or in state hospitals in general to deal with the issue. And my point to all of you, and particularly to this group, is that the initial point of admission is a critical point for beginning the process of recognizing people who are at risk. It's extremely important to check on presenting information from the referral source and inquire directly, if possible, whether this person has ever attempted suicide in the past. One of the ways that this can be further documented is to check the nature of the 302 commitment, if there was a 302 commitment. Now, that might seem obvious, but one of the things that I'm doing right now professionally is introducing and field testing a system of doing initial screening of persons who contact community mental health centers and mental health agencies in the community, either by phone or by walk-in, their initial intake contact. And what we've done is set up a very basic system of items that have been scaled for severity that provide a structured and uniform way of interviewing the person regarding issues that are relevant to deciding how quickly they should be seen. Since not everyone can be seen at once, there has to be a method to decide how to set priorities, and that's what this system is about. We have one set of scales for adults and one set of scales for children and adolescents. We field tested it in several counties in Pennsylvania already, and one of the things that amazed me about our initial results is that while the intake workers were cooperating with the field test, and we had done a lot of preparation to enlist their opinions and support, while they thought they were doing a very conscientious job, there was one option on the scale, information not available, because there were some items where we felt that might be a reasonable response, but certainly not for suicidal ideation and suicide, recent suicide attempt. And in some counties, not all of them, in some counties, on those two items, the information not available was as high as 40 or 45% of the people coming into the center. Not never, there was a never response, or in the distant past or within the last 3 months, we had it graded in terms of recency, but information not available. And when I went back to discuss these results with them, I said, I really can't understand what this means, because first of all, I would want to know from a liability point of view whether this was true or not. It's one of the questions that I will regularly ask people in a first interview when I see them in my private practice, and often on the telephone if they're asking me, can I see them quickly? And there's a sort of urgency in their voice. I will broach the issue with them on the phone. I want to know about this. And from a provider agency point of view, because of legal liability, it's even more important. And many of the intake workers said we were embarrassed to ask, or we felt uncomfortable about asking this question. So don't assume that because what I've just said is obvious and it makes sense and would be good practice that everybody does it. And it's not just intake workers who fail to do it. It's a topic that people up and down the line may neglect to ask about. The next opportunity that you get to talk about this issue is when you do a more formal intake history and interview with the patient. This is beyond the admission process. And here you have an opportunity to discuss what may have been reported in the admissions data itself, but if it doesn't say in the admissions data that this person has attempted suicide or had suicidal ideation, don't use that as a reason for failing to ask about it again in the follow-up and more thorough clinical intake interview and assessment. And the third point in the flow is where you can use information from admissions and the intake history and interview, and then focus in more closely on what may be involved, and that is any kind of formal psychiatric diagnostic evaluations that are done. Now, that varies from hospital to hospital, treatment setting to treatment setting. Some people will do formal psychiatric or psychological diagnostic testing only when it's ordered by the court or requested specifically because they want to make a distinction between whether this is an organic, what people used to describe as organic or functional disorder. It's not done routinely, of course, because there's a cost attached to it, and it might not yield that much extra information. But I would suggest that anybody who has any indication or record of a history of suicide attempt should be scheduled for some type of formal psychological and psychiatric evaluation around this issue. Which moves us now to the question of how do you evaluate risk at a clinical level? What kind of instruments are available? What type of techniques can the clinician use? Well, I have to tell you very frankly that the materials that have been developed thus far are not terribly impressive, and they have, from a strict scientific point of view, a number of weaknesses as instruments. But I think that it's still worth using some of them because they do provide a uniform method of evaluating people. You're going to be asking basically the same kinds of questions of each person so you can compare cases as time goes by. If you simply have a judgment that someone has a high risk of committing suicide and some narrative notes in a record, from case to case, people may have asked different questions. They may have used different indicators to decide whether this person is at high risk or at low risk. And it's very difficult to use that information in a collective fashion. So if you use some type of instrument that is uniform, you overcome that problem. And also, it probably will provide a more systematic interview process. People think that they interview more systematically than they do, but the best assurance that they're doing essentially the same thing each time as the core of their inquiry. They can ask different questions, additional different questions to add on to this core inquiry, but the way to make sure they're doing the most consistent core inquiry is to have some format, some schedule of questions to work by. Now, I've forwarded to you folks some materials, and you should have something in your possession that is identical to what's on the screen right now, assessing the degree of suicidal risk, intensity of risk. This is a very simple instrument that's been developed to help assess the level or intensity of risk in the immediate present and then over the next 12 to 18 months. And attached to the set of items were two case histories. Case number 1 for Mr. Smith and case number 2 for Mr. Jones. And as the written material indicates, it's only in the recent years, based on data from recent research, that the necessity for rating both short-term or emergency and long-term risk has been recognized in treatment settings. It's valuable to know the difference between these two ratings and determine the factors for discriminating between them, because you will do different things depending on whether you're focusing on the short-term risk or the long-term risk. And different factors will have greater weight in defining short-term over long-term risk. In the case study of Mr. Smith, if you have had a chance to read this already, you'll recognize that the authors came to the conclusion that, in their judgment, using this instrument, that Mr. Smith was a high short-term risk case, but that over a long term, if they could get him through the short-term risk period, over a long term, he was not a high-risk case. And reasons for that is that even though he was exceedingly upset because he's beginning to reach midlife in terms of age, he's 45 years old, his wife of 20 years has indicated that she wants a separation from him, that he's not satisfying her as a spouse any longer. Children are no longer in the house. And he's exceedingly upset and depressed about the situation, hasn't been functioning well at his job, been drinking a bit too much, and he does have guns available to himself because he's a hunter and a sharpshooter. And he's very angry. You might think that he was a high risk on a long-term as well as a short-term basis, but the investigators report that he feels suicidal and a highly lethal method is available to him. However, as a long-term risk, he should be rated low because of his stable lifestyle and the coping strategies available to him, which are reported in the case study. He does have hobbies to occupy his time. He has friends and family for emotional support and a demonstrated ability to invest himself in other people. The likelihood is that Mr. Smith, if he receives some help within the next 24 to 48 hours, will be able to stabilize, and if he gets this emergency help, the risk of suicide will be reduced. And going down this instrument and talking about Mr. Smith, find that right now in the immediate present, he's highly anxious, he's at least moderately depressed, but he's not isolated and withdrawn. His daily functioning is moderately good, and he has several resources rather than few or none. His coping strategies and devices are generally constructive, even though he tends to be angry right now. There are significant others who will remain in his life, even if his wife separates from him. He has family and friends, and his lifestyle is quite stable. His alcohol and drug abuse is infrequent. He has no previous record of attempted suicides. He has no psychological disorientation or disorganization. His hostility is intense, but it's related to the crisis in his life at the moment. And his suicidal plan, while it's rather frequent and it is specified, is offset by the other positive factors. So that what you notice about him is he does have to be watched very closely in the next 48 hours because he has guns. You have to make sure he doesn't have access to these. He has to have a way to release his anger and his rage. This is a part of what therapeutic activity can be done with him. And basically, he needs to be counseled and reassured on the fact that if he can get through this period, that his life will straighten out and that he does have reasons to go on living. Now, you can't get a neat score out of this instrument, unfortunately, but it does provide one method of beginning to get some kind of a focus on a person who is presenting as an attempted suicide case. The second case, Mr. Jones, can be rated using the same scale. I'm not going to take time now to go over the second case because I think that it's pretty clear how that case is evaluated using this intensity of risk profile, similar to the way in which case number one is evaluated. And again, I would say that even though there are many obvious shortcomings with this method, if you have no systematic method, it's certainly much better than none. Now, for a more structured and scorable instrument, I've also had sent forward to you a scale called the Index of Potential Suicide that was developed a number of years ago by a psychiatrist named Zung. You may know Zung because of work that he did in developing depression scales as well. He has a number of instruments that can be used for quickly evaluating patients in terms of their degree and severity and extent of depression. What Zung has done is to take 50 items and organize them into scaled items in which you can evaluate the client from 0 through 4 in terms of severity. There are 3 versions of this scale. I've only forwarded 2 of them to you. The third version is worded so that the client or patient can rate themselves. Now, there may be enough instances of patients here at this hospital who could rate themselves that you would want to consider a self-rating scale. These have become popular instruments in the last 20 years. You may know the SCL-90, the SCL-90R, and the shorter versions of that scale are scales to evaluate a whole range of psychiatric symptoms, and they can be done by the clinician and or by the patient. The notion of having the person rate themselves is they might be more candid and truthful on some items than they would be if they were asked the same question by someone else or in the presence of someone else. But I've included the version in which the clinician does the evaluating and a second copy in which a significant other, someone who knows the patient, either a family member or if they've been in the hospital for a while, it doesn't have to be a family member, it can be someone who's on the ward with the patient. It can be another member of the hospital staff. The point is you get two perspectives on the same item. They're the same items, all 50 items occur on both scales, but they're worded in such a way that you're getting two different perspectives, and you have the advantage of being able to compare the response on each of these items from two different perspectives. Gives you a bit more reliability and focus on the behavior. Zung indicates that items 1 through 20 deal with depression, 21 through 25 deal with anxiety, 26 and 27 deal with alcoholism and substance abuse, and 28 through, that's not through, it's 28, 29, 30, 31, and 42 deal with general health, and items 32 through 41 deal with emotional stability or status, and items 43 through 50 deal with suicidal behavior. I've gone through this and I've used it a few times, and my own kind of informal factor analysis or evaluation of how these items hang together in groups and actual formal statistical factor analysis group them in a slightly different manner so that I don't completely agree with Zung about which items are the ones related to depression, anxiety, alcoholism, general health, emotional stability, and suicide, but they're close enough. There's a good deal of overlap. And the way you would score this scale, the range of scores can go from 0 to 200. The maximum score that anyone could have would be 200, but they would be a pretty unusual case. In fact, let's look at what Zung has found in some of the studies that he's done in using this scale. Zung found that in a study that he conducted, which included subjects that had no suicidal attempts or behavior, ruminators, or people who thought about it and talked about it somewhat, had suicidal ideation but never took any action, those who had carried it one step further and made convincing and active threats, and finally a fourth group of those who had actually attempted suicide, that the mean IPS score using the interviewer-related technique was 43.2 for no suicidal ideation at all, 61.9 or about 62 for ruminators, 71.8 or about 72 for threateners, and 72.8 or about 73 for attempters. And the standard deviations, as you can see, carry a good number of cases well above these scores, but none of them approach 200. So that we're talking about people who have a mixture of strengths and weaknesses typically, a set of risk factors but counteracting factors as well. It is interesting to note, and speaks to the utility of the scale, that those people who had no indication of suicide scored lowest with a score of 43.2, and the rank order follows what we would expect if there is some relationship between history and previous involvement with suicide and the risk of committing suicide. The ruminators are next with a score of 62, the threateners at 72, and the attempters at 72.8. On the individual items or factors, on the depression factor, the same order prevails for the most part. Of all the depression items, the mean score was 1 or very mild or minimal for the none group, and was still only at about mild for the attempters, but this is just on a given factor. And the two factors that have the highest mean scores for the attempters are depression and general health. Another problem I have with this particular scale is it uses suicide and items on suicide as part of the material to predict suicide, and I think it would probably be preferable if they were kept separate on an independent scale. Now, let's look again quickly at what things look like when a significant other does the rating. First of all, you see that a significant other, who happen to be family members in this case, tend to see persons in each group as being at greater risk than the clinician. The score for attempters, the mean score for attempters done by clinicians was about 73. The mean score for attempters done by a significant other is 85. So that there's a significant difference in mean score. And the standard deviation for the clinician was 26.4. For the significant other, it's 30.9 or almost 31. So they tend to score them as at higher risk, and there's a greater dispersion or range of scores for the significant other. On the other hand, the rank orders maintained for the most part. Threateners score a little bit higher than attempters, but basically the rank order stays the same. And depression and general health are among the top factors, although by now anxiety comes up and is pretty close to depression and general health. Now, we recall from the stressful life event study that we looked at, that one of the major causes among suicide attempters in that study were problems with general health. And that was true for both persons who had attempted suicide and persons who were depressed, but it was even more so for people who had attempted suicide. So general health comes up as a factor, and we don't want, even though the risk of committing suicide is so much higher for people who have psychiatric disorders, we don't want to make the mistake of thinking that their general health in combination with whatever type of psychiatric disorder they have isn't a potent factor, and it does seem to be so. And it's just not a matter of the significance of general health problems for people in the population in general who have enough personal, psychological, emotional resources to deal with this. It's people who have problems with their general health who don't have these supportive resources and may also have a psychiatric disorder that puts them at such high risk. So we begin to see another way of developing a profile for suicide risk by looking at the entire person. What type of social supports do they have? What's their general health? What's their psychiatric status? And how recently have they encountered stressful events that may precipitate some attempt at suicide? And being admitted to a state hospital, even if it's a very caring and effective state hospital, is certainly a very stressful event because whatever the care is like on the hospital side of the issue, a person is now defined in their general community and their family in a way that they will probably never be able to change again. They've been sent to whatever the community calls the state hospital, the loony bin, the nut house, the place where crazy people go, whatever the different stigmatizing terms are that still exist out there in great frequency. This person now has that label on them, and they're aware of it, and they know that the return to community is not going to be a simple matter. So the admission to an inpatient unit, especially a state hospital, is definitely a stressful life event. One of the items that's on the Zung scale that I wanted to draw your attention to because it's an item, several of them actually, the anxiety items, are related to a condition that is being reported with greater frequency both in community and in hospital psychiatry, the condition of panic disorder. This seems to be one of the disorders or psychiatric diseases of the 70s, 80s, and moving into the 90s. I see an increasing number of cases where people are referred to me in my private practice who have panic disorder. And generally the way I deal with that is to work with a psychiatrist, and he handles the medication aspect of it, I handle the therapy part of it, and together we work as a team. That seems to be an effective method of working with panic disorder. But item number 9 on the Zung scale is tachycardia, which you may know is a very, very common indicator, one of the most common symptoms that goes with panic disorder. And there's another item on feeling that you're falling, apprehensions, 25, have you felt that something terrible was going to happen? This is also another subjective report of people who are suffering from panic disorder. And if they've had it for about a month or two, then they also begin to feel hopeless and helpless because the attacks come back, and each time they come back, they seem to be even more overwhelming than the time before, and very quickly people begin to develop a sense that they're never going to be free from this condition, and that is when they start entertaining ideas about suicide. Now, there hadn't been much in the literature about that until very recently, but I have one table here that gives us some information on suicidal ideation and panic disorder. And this came from an article in the New England Journal of Medicine reporting that 20% of panic disorder subjects had attempted suicide in this particular study, which was part of an epidemiological study of the general community, compared with 12% of those with panic attacks, 6% of those with another psychiatric disorder, and only 1% of those with no psychiatric disorder. So that in full-blown panic disorder, the percentage of persons who had attempted suicide is significantly higher than in any of the other psychiatric categories, and much, much higher than those who have no psychiatric disorder whatsoever. And the kinds of items that showed up as discriminating the panic disorder group from the others were thought a lot about death, felt like you wanted to die, felt so low, thoughts about suicide, and had made suicide attempts. So that this is a specific condition that hasn't previously been identified as having a great deal of significance for identifying people at risk for suicide, but increasingly is becoming recognized in that respect. Now, another source or another area, leaving these particular scales for the moment, and what I would recommend, by the way, is that both your committee here at the hospital and those of you who are just interested in this topic look at the Zung scales and see if there's a way in which you might, on a pilot basis, want to use them or modify them somewhat to suit your own purposes. The biggest weakness or shortcoming of all of these instruments for predicting and evaluating risk of suicide is that because it's a relatively rare event and because there's almost always a difficulty in conducting these studies because of the reluctance to disclose attempted suicide and suicidal ideation by patients and family members, there aren't any really very good baseline data or norms. When you see in Zung's study that attempters had a mean score of 72, the only reason that has any meaning at all is because you can compare it with 3 other groups. But otherwise, 72 doesn't mean anything at all in its own right. So what you have to have are relevant norms or baseline data against which you can compare the scores of people who are evaluated on these instruments. And I think the best thing you can do is develop your own local norms, as well as attempting to find out if other people have used instruments like the Zung instrument and use their norms as well. There is no precise formula that you can use to calculate someone's risk of suicide. On the other hand, if you aren't using some kind of systematic instrument to evaluate the risk of suicide, you're doing less than you could do and less than what is done in institutions where this is taken as a serious part of the practice of mental health services. I don't think anyone has found any, if I'm understanding you, I don't think anyone's found any indication that looking for it increases the rate. It doesn't agitate patients or suggest or promote suicide. I don't know that I can say that I've seen any studies that dramatically indicate a reduction in suicide, but again, that's because most hospitals with a medium-sized patient census, 600-bed hospital, 800-bed hospital, they're probably only going to experience 1 or 2 suicides a year, if that. They may experience many more attempts, but so it's hard to see a dramatic reduction because you don't have a lot of frequency to begin with. But I still think that even if you can't demonstrate that you have to take the position that if you weren't doing this, certainly the risk wouldn't go down. So it's a part of responsible care in which the justification is largely you do this because this is going to be in the patient's interest, even if it doesn't show up in statistics right away. Another important source of information that's often neglected and just not systematically built into the way hospitals deal with the issue of suicide and suicide attempts is utilizing on a fairly systematic basis staff observations. And I mean all staff, from ward attendants to LPNs to RNs to psychologists to social workers to psychiatrists to whatever. There's no particular profession that is going to have a monopoly on making observations or having access to information from a patient about whether they're thinking about something as personal as committing suicide. So that I think another thing I'd recommend is that you review the process by which this information would be exchanged and shared within the hospital. It may be totally unsystematic right now. It may be there, but there's no guarantee it's going to go any place or go any place where it can be acted on. A false report is no worse and probably better than no report. Any report has to be evaluated in terms of its seriousness or its utility. No one wants to prematurely react to a report, but a false report is not going to cause somebody to commit suicide, and if anything, it's just being a little more conservative than usual in the way you approach the issue. So staff observations, suspicions, intuitions, and reports, and depending on the hospital and the atmosphere in the hospital, I wouldn't even exclude patients as a source, other patients as a source of information on possible suicides. Jim mentioned last time when he was introducing me that I spent about 2 years working at Philadelphia State Hospital back in the early 1970s. This was before, for what I think are a variety of reasons, in addition to improper care and patient neglect and a blue ribbon panel report, the hospital was closed. This was at a time, in fact, when I was there because I had left a position at a medical school because, believe it or not, there was a Pennsylvania State Hospital that had such a positive reputation that it was a place that you went to study and learn about the treatment of patients who were seriously and persistently mentally ill, and there were several people, including the person that I worked with, Bernie Wyman, who had a division in the hospital, a clinical research division, and we worked with patients who were being discharged into the community, and instead of doing what people were accused of doing, just driving patients out of the hospital, we would identify cohorts of patients who would be ready to go in 8 months or 14 months, and then put them through a program that was called resocialization to get them ready to go back into the community, which included trial visits into the community. And you have to realize, of course, we were dealing with people at that point who had been in the hospital for 25 years. They had forgotten about things like making change, how you get on a bus, how you get off a bus. Almost anything about ordinary community living had to be reviewed with them, and they had to get practice at it. Well, in any case, not to go on about Philadelphia State Hospital, but that's an issue that I still react to a little bit. I think that the way that hospital and state hospitals have been represented by people who have political motives for closing state hospitals is highly irresponsible, and the press I don't know whether they mean to or not, but they do an abysmal job of representing the issue in the press. In the Philadelphia newspapers, they had a photograph in the Sunday Inquirer magazine section right around the time they were closing the hospital. Strong evidence of abuse. There was a patient in a quiet room, and there was nothing in the room. Well, that doesn't surprise us, does it? And they made a point of that this was just a room with nothing in it, and they had taken this poor, distressed, agitated person to put them in the room. I don't know what they wanted, a coffee table and a mirror and some candlesticks and a couple of sharp knives. It really amazed me, the naivete of this reporter, and he was indignant because this person was in a room with nothing but a leather-covered mattress and some padded covering on the walls. And then there was another photograph of a patient playing solitaire. We've learned a lot of different things about schizophrenia in the last 20 years, and one of the things that we've learned is that for certain schizophrenics, when you get them to a certain level of being stabilized, don't overstimulate them. It's not good for them. You can give them challenges, but don't overstimulate them, and especially at certain points in their recovery. So this patient was happily playing solitaire, and the aide was looking on, and the reporter complained that the person was being left to play solitaire. I don't know whether they expected a four-handed bridge tournament or what, but it just really annoyed me and amazed me, and I guess I had to get that off my chest. I see there's still a little bit of emotion in me about criticizing large hospitals when they, like anybody else, they have times in their history when they're excellent and times when they slip a little. And I happened to be at Philadelphia State Hospital when it was an excellent hospital. And one of the things that I learned about patient care and relating to patients in that time period was that patients are very much aware of many patients are very much aware of what the social structure of the staff is. I would have patients come in after they got to know me and give me their observations on what was going on among different staff members, and often it was very accurate. They were very perceptive. They saw conflict, tension, competition, recognized that things were changing because one person had managed to succeed in having their views override someone else's. And they also were very much aware of, well, I say very much aware. I don't mean all of the patients, certainly. I don't want to exaggerate this point. But some of the patients were impressively aware of what other patients were feeling. There's a whole level of communication and information exchange that goes on within an institution like a hospital that patients are plugged into, that they participate in, and which sometimes they make an excellent source of information. So my point is, I just wouldn't exclude them in this flow of information on suicide by any means. Now, what happens when an actual suicide attempt occurs or is successful? Well, of course, it's a medical event, it's a treatment issue, and it's a legal event. But in terms of what we were saying earlier about meaning and intention and the human aspect of suicide, it's also an event that affects everyone in the hospital. It affects the staff who were responsible for that patient. It affects other staff who hear about the suicide. It affects other patients. And of course, it will affect the family when they find out about it. A number of large hospitals have been experimenting over the last 5 years with the concept of developing some kind of formal response to a suicide. One example is reflected partly in material I handed out to you called the suicide postmortem record, which is one concept. This is a formal method of reviewing a suicide after it has occurred. It has factual value in that you are collecting information about when it occurred and who the surviving relatives are and the method, who were members of the patient's treatment staff, etc., who were the patient's main companions in the hospital. But as you move through this information, you also move into the area of what can be done in the way of some kind of ritual or ceremony to deal with the fact that someone who was in the hospital has killed themselves. Typically, a suicide occurs, it's reported, it's investigated from a forensic point of view, and a medical point of view, and then everybody tries to forget about it as quickly as possible. That's probably the most unhealthy and least professional way that you can deal with this kind of an event, because what's happened is somebody ended their life, and they did it in a hospital, and they were under care, they were under maximum protection to prevent this thing from happening. It isn't a question of whether someone's at fault or not. That's the forensic and the legal issue. What remains is, how do people deal with this very basic, primitive issue of life and death? Patients mean something to each other. As I said, patients develop friendships, love affairs. You have any, this is something that also gets people very nervous, but when I was at Philadelphia State Hospital, one of the studies I did was on the hospital culture and community. Yes, we had this hospital with, at that time, maybe still about 1,200 patients. I forget the staff level, but we had our own fire department, we had our own kitchen service, we had our own general hospital, we had our own library, we had our own theater, we had the wards, we had grounds where people walked around. This was a community on the edge of a community, and it was occupied 24 hours a day. Some people coming and going in shifts, but basically there was a continuity of communal life. And everybody there was about 18 years of age or older. And you have to understand, when you get that many human beings together in a community, the things that happen in communities happen there also. They're a little exaggerated and distorted and bizarre in some respects, but they're much more normal than people realize. And death in a community is handled through ritual and ceremony. Death in a large hospital is often ignored. It requires ritual. It requires recognition. It's very important, for example, to let all the other staff know as quickly as possible that the suicide has occurred, so they're informed with basic facts. They don't have to know a lot of detail, because people will ask them about it. And they may feel some resentment and emotional distress if they find out about it by having to answer a question they can't answer 2 days after the event occurred. It's important to give a basic set of information to the patients who are on the ward or in the treatment group with the patient who committed suicide right away. And it's also important to make arrangements on at least 2, maybe 3 occasions, but at least a few occasions in the ensuing weeks for treatment staff to talk with the patients and patients to talk with the treatment staff about how they felt about the suicide, about what it was, what it meant. Now, maybe this sounds a little idealistic, but I can guarantee you, and I will be glad to give Jim a copy of an article that reports on a hospital in which they have not only a suicide post-mortem system introduced, but a whole ceremony, a whole procedure for dealing with this, and do it regularly. They found in the course of talking to patients that some patients actually felt that they changed their mind about their own possibilities of committing suicide because someone they knew had committed suicide. They actually felt they were less likely to do it. They thought through it. Now, if they thought through it and they didn't have a chance to discuss it with anyone, it's less therapeutic than if they thought through it and they had a chance to discuss it with someone. And if they know that it's okay to discuss it, that it becomes a public reality that isn't threatening and stigmatizing. Staff often feel guilt and anxiety and shame about this sort of thing, and yet consciously they'll deny it because we're all professionals and we all know it's part of the game, and you don't get upset about this sort of thing if you're a professional. But the fact is, besides being professionals, we're still also human beings, and we do get upset about it. So I think that it is really extremely important that people consider introducing some kind of ceremony and method for dealing with suicides when they occur. And I would recommend that that process be considered here. There are a few case histories that I've included in the materials that I handed out to you. I'm thinking right now, looking at the clock, it might be more valuable to you folks if I stop at this point, and instead of going through these case histories, which you can read on your own, and some of you may have seen one or two of them before, if I just stop right now and we use the remaining time for you to ask questions or make points that you feel I haven't made, although I'm the person who's standing here at the podium, it doesn't mean I have a monopoly on knowledge either, and you may feel that I've overlooked something or neglected something you want to share with the rest of the people here at the hospital. So why don't we just kind of use this time for some discussion? Is that okay? Yeah. Suicide contagion is a phenomenon that's been reported in the literature. There's not a lot of hard data to document that it occurs, but there is some, and it seems to be something that definitely occurs more often among adolescents and young adults, especially if they attend a school, a public or private school where a suicide takes place. The risk of suicide contagion or imitation is certainly higher among persons in hospitals where they're there for long-term care than it is in the community in general. But I have to say that this is an area that's been talked about a lot more than it has been studied, and so I can't really say to you, these are the studies that provide hard data that if one suicide occurs, the risk for other people is at such and such a level. I think that it's certainly something that ought to be considered as a real possibility, and it's much more likely to influence someone who is already approaching the possibility of attempting suicide or has fairly strong suicidal ideation than just anyone in general. So that it's not a simple imitative response of a behavior, but an additional factor that could precipitate an attempt if someone's already moving in that direction, so that you would want, again, that's all the more reason to have fairly good information on your patients, know which ones recently seem to have come at risk, and then watch them a little closer and be more interactive. It isn't, I don't want to say watch them more closely. It's not that's the idea of watching them from a distance and keeping them safe from harming themselves. That's as important as letting them recognize you're aware of this issue they're dealing with, and included in the interaction and relationship with the patient, of course, is the observational aspect. Now, if someone's actually made a suicide attempt, the most common and probably still the most practical method of dealing with it for at least the first week after the attempt is to keep them under constant observation as long as you can afford to do so. And I mentioned last week, it gets pretty expensive pretty quickly to do that. And then there's a whole question about who's qualified, what personnel are qualified to keep the person under observation. for legal reasons as well as professional reasons, some hospitals maintain you have to have at least a registered nurse with training in psychiatric nursing, at the very least as the person who's doing the observing, and preferably someone with additional training. You can't, what hospital could afford to put a physician, a general physician or a psychiatrist watching one patient for 72 hours? It's not going to happen. That issue is still not resolved. Who's qualified and what does it mean to put them under observation? But I don't think that's nearly as important as the larger package of conveying to the person who is at risk because they've recently discussed and maybe made threats of committing suicide, or they've made an attempt, that their behavior is of great concern to the staff, and that there's an effort on the staff's part to reach out to them in many different ways besides just observing them. That probably would do more than anything else to reduce the risk of contagion. Did I address your question? I'm sorry.
What percent of the suicidal individuals are alcoholics?
When they're
What percent are alcoholics?
well, yeah, the question is what percentage of persons who attempt and commit suicide are alcoholic. In general, if I quickly average the different reports that I'm familiar with, substance abuse, alcoholism, or narcotics addiction, either currently or recently in the past of that person, is common in about maybe 70% of the cases. It's very high. The meaning of that finding can be looked at a number of different ways. For one thing, if the person is suffering from some form of substance abuse problem, they have, if they've been involved in it for a while, they have disrupted many aspects of their life. They've probably driven away people who would have been their previous support system. They develop a sense of hopelessness and distress because they are on a downward spiral in their life. In addition to that, alcohol and drugs are disinhibiting substances. They make us more likely to act on impulse, and they anesthetize to some extent, so that we're less concerned about and feel pain less intensely, so that we're more likely to entertain highly lethal methods of committing suicide. When you combine all of those factors, alcohol abuse and substance abuse is a fairly common factor among people who commit suicide.
In reference to the idea of contagion versus learning that someone has suicided and having that have a positive impact on your own suicidal ideation, can you make any differentiation on why one is the other negative?
Well, yeah. It's a good question, and I'll be honest with you, I'm really kind of answering the question for the first time right now, so I'm thinking about the answer as you're asking the question. It seems to me, this is more of an opinion than anything that I can back up with facts right now, that when you begin to deal openly and intentionally and consciously with the event, you're changing the meaning of the event by broadening the possible alternatives or ways of reacting to it. When you don't discuss it and open it up for public consideration, people will react with whatever response they see or feel is available to them. And if they happen to be, again, to go back to my point, already considering suicide or highly at risk of committing suicide, other options to dealing with this tragedy are limited to them, and it simply confirms their own sense of hopelessness. They see themselves acted out in the suicide case. I'm next. They presented the model. I had so much in common with them. I'm just like them, so I'm next. But by talking about it and having it become something that's shared with people, other solutions and interpretations of that behavior are made available to this person so that they're less likely to be one-option thinkers, and that reduces the risk of suicide. That's why I think it's different. Yeah. I'm sorry? Well, you're raising a good issue for discussion. Covers a lot of different points. First, and we really didn't get into that, and that is, how do you convey your own personal as well as professional values and attitudes towards suicide and the acceptability of self-destruction to patients in general, and particularly to those who have confided in you that they have had suicidal thoughts and perhaps are entertaining some attempt at suicide. If you immediately suggest to the patient that this is unacceptable to you personally and professionally and otherwise, about all you're going to really accomplish is that the patient will probably not discuss it with you again. You will lose contact with that person. The avenue of communication is closed. On the other hand, you can't ethically suggest to the person that it's as good a solution as any other, and that you're totally value relative, because legally you can't take that position for anyone, but particularly for a professional. To know that someone is seriously thinking about suicide or planning an attempt and not take appropriate action is, by law, tantamount to making you a co-conspirator in the suicide. And ethically, you can't do it because, even if there weren't this legal consideration, because your ethical commitment is to help people get better, and they don't get better by dying. That's a radical solution. So you have to have a way of conveying to them, at the same time that you're listening to them, that you ultimately don't approve of suicide, and you hope that you can convince them or persuade them not to use that strategy as well. How this relates to your specific question is by doing something that all professionals have to do, which is a difficult thing to do, but that's presumably what we learn to do well in time. Now, that is to keep jumping back and forth between two different roles. One of them is the role of the professional that sets very definite limits and boundaries that are acceptable and reality-based, and at the same time jump into that other role where you can be at least a temporary confidant to the patient, so that they can speak to you with a sense of not being concerned about prejudgment or being acted on because of something confidential or they're relating to you. You don't have to empathize with the patient up to the point where you can really understand why they want to commit suicide and endorse it, but you should and can empathize with them up to the point of recognizing that this is one of several ways in which a person might react to the situation the patient is in. That much you can convey to them and to yourself. I think by conveying to them that beyond that point, you still believe that the preferable solution, and the one that you're going to support, is finding some other alternative to suicide, is how you maintain for yourself that emotional distance that you have to maintain in treating the patient. If the patient doesn't respond to your efforts to help them avoid committing suicide, if they do commit suicide, then I think that you have to recognize, in terms of what I've been saying, what's in the literature and what's generally accepted, is if you've done everything that good practice model or proper care model includes, then you've done as much as anyone could do, and this person committed suicide. It was their act, it was their suicide, and you can't take responsibility for the fact that it occurred. That's why when I was in graduate training, I had a professor who said there are two things that you must, there are a lot of things you'll do and ways you'll screw up as you go through your career. Everybody does, and you'll get better and better at what you do if you're really concerned about it. But there are two things that you can never screw up at and expect anybody else's support or understanding. All the other things, people say, well, he's learning, she's learning, they'll get better. The two things you can never screw up at is you must never have sexual relations with the patient, and you must never ignore a suicide threat. Because if you do either of those two things, other professionals will say you didn't do what you knew was professional, and don't come to us looking for support or understanding. And I think if you do everything that is known that can be done, and it still doesn't prevent the suicide, then if you're a mature professional, you should be able to deal with it if it occurs. But it still doesn't hurt to talk to people about it and admit that you feel some regret that you couldn't prevent the suicide.
Wrote an article talking about this business of being such a rare event, not only difficulty getting home, but say you had a test that was 90% predictive, and say the rate was in a hospital, say was 10 in 1,000, you'd have to have you'd have almost 100 false positives.
Yeah.
And so, but it's still a test like that might be useful, even if you had 100 people as a screening instrument. And one group that I didn't even mention, it seems to me that the nurses, aides, and things like this who are here at night, and professional staff really are here 8 hours, and that might be a time when the patient that you're seeing is not behaving the way they behave at later hours, and how important it is that we get the communication for people who are on midnight shifts.
Oh, absolutely.
And the kind of data, and if they know what they're supposed to do, and they know about the risk of suicide and all these kinds of things, if they're well trained and can get that information to people when they come on board at 8 or 9, that might be another. That's where you go further into it.
Very good point. They should be included in training. They should be included in any kinds of groups that meet to discuss policy and procedures, and there should be a systematic way in which they can make this information available to people coming on. Absolutely. Yeah.
That's why we take recordings. Because they can be shown second and third shift.
Good.
We realize that this one, the patient is here 24 hours a day.
Well, it's easy for a professional to think of the hours they're here, and that's what they have a full
You're absolutely right.
patient behavior is often like
Yeah.
Think there's any usefulness for the so-called no-harm contract where you just have some kind of written agreement with the person that they agree to call you if they're thinking of attempting suicide and so forth? Not from a legal point of view,
Yeah.
but from a therapeutic point of view.
Jim's asking me about a relatively recent issue of no-harm contracts. I think that they potentially can be another useful technique. I think anything that helps to bring focus and formalizes this issue and moves it away from something that is to be denied or ignored or to be ashamed of, and moves it into an area where people are going to take responsible action, patient and practitioner, should tend to work in the interest of reducing the risk of suicide. And I don't know if there's enough information available yet to say whether it really does benefit or not, but I can't think of any reason why it wouldn't, and I would say it's definitely worth trying. So. Okay, thank you again. My pleasure being here.